Ladies and gentlemen, dear colleagues, thank you for joining us in this webinar today. I would like to thank the organizing committee, the company Novodent, and also the AIM Academy for inviting me and giving this lecture. And the title of this lecture will be Short, Shorter, Ultra Short. And ladies and gentlemen, I'm going to talk about implants. So short, shorter, and ultra short is all about dental implants. Now, a small word of me, I was already introduced. Just to know what I did in my past, I did my studies mostly in Belgium at the Catholic University in Leuven. Afterwards, I did a master in clinical dentistry in the University of the Pacific in the US. And in my academic career, I worked at several universities, in the beginning in Belgium as consultant, but later on as assistant professor in Germany, associate professor in Manchester. And for the moment, I'm working for the Ulster University in Birmingham, and there I am head of the implant dentistry department. I published, well, more than 40 international scientific publications, also some national ones and some chapters and books. And since I have so much free time, I also try to do my job as editor-in-chief of the Journal of Dental Health, Oral Disorders and Therapy, and the Journal of Dental Reports. I'm lecturing all over the world, but today, in these strange times, it's mostly online like today, and the topics that I lecture on are mostly ceramic dental implants, ultra short dental implants like today, concentrated growth factors like LPRF, and the full digital workflow. In research, I work also for the company BioRise's Camlog as a consultant, and for some other companies. And I'm very proud to be honorary fellow and ambassador for the Clean Implant Academy, also ambassador for the European Society for Ceramic Implant Dentistry, and I work as lecturer for the Tipton training. That's more than enough about me. I just would also like to thank the AIM Academy for having me here. If you want to know more about it, then I really would advise you to look at the website of our academy. The mission, the really important mission that we have, is to provide scientific support to acquire knowledge and experience in the field of implant dentistry, to support the clinical trials to create evidence-based information, because that is very important. We don't want any product that comes on the market without any preclinical or clinical trials to support the value. And finally, for me, very important is to build a social network with people who have the same interests. For the moment, this is very difficult. We know in these COVID times, we mostly sit at home or we spend our time before screens like today. But building up a social network with people who are in the same field is very important. And that's part of the vision. Bring people together to share the existing knowledge and to update continuously the information that we have. And this is the only way, I think, that we can improve what we do today in our own clinics. This was one of the images of myself then for the AIM Academy. We had a big congress in Ukraine, in Kiev in 2019. There were a lot of people there, very interesting. And also, as I said before, the social coming together to discuss things, what we are doing, quite important. Now, introduction. Let us start now with the webinar itself. And let us start about short, shorter, ultra short. Now, the first question that came in my mind was, what is short? What is short for you? And let's go back to antennas on cars for radios. And when you go back to the 80s of the last century, and you saw there, I think it's an old Mazda or something, you had an antenna, and the front side was quite long. And if you were lucky, you had some music in your car. A generation after, there was a smaller antenna, already a shorter antenna, that was on the back of the roof, and you even got better sound in your car. And nowadays, at least on my car, I have something like this. It's completely short, and the quality of the music in my car, if it is not coming from my telephone, it's quite amazing. So what is short? That changes over time. Now, there was a European consensus conference in 2016 who really stated what is short and ultra short. And it is very simple. Standard implants from whatever company, I'm not talking about the company now, have a length of 8 millimeters or more. Short implants are less or equal at 8 millimeters. And ultra short implants are implants that are shorter than 6 millimeters. So a 6 millimeter implant is not an ultra short implant, it's a short implant. And to go quickly to the eye system, what we will talk about later on in this topic, I would like to see the whole portfolio. And when you look to the whole portfolio of the eye system, you see that they have a standard implant. Standard implant means more than 8 millimeter, that's 10. You have short implants, shorter than 8, but not shorter than 6, so they have 6 and 8. And you have ultra short implants, 4 and 5 millimeter. Now, the second question is, how short can we go? Maybe some people think at the first slide, this is already a short skirt. The middle is maybe shorter, but can we go shorter? And you know, today it's all about #MeToo. So if I showed this slide 10 years ago, no one was making any comment on that I showed legs of women. But today I'm so clever that immediately I also show them men, so that there is no discussion about the fact that the #MeToo movement could be aware of my presentation. So how short can we go? What is short for you? Is the middle guy someone with short hair, or is the other one someone with short hair? Now, if we go and look to regular implants, we can see how short we can go. First of all, if you go to the classical external hex implant, external hexagon implant, and that was the type of implant that I was trained with, the external hexagon from Bronnemark, there the shortest way you could go was 6 to 6.5 millimeter. And the reason is that you have to put the internal screw deep enough to have a stable connection. So if you would go shorter than this, then the internal screw would come too short and your implant abutment connection would come loose. On the other hand, if you work with implants with an internal connection, like a Straumann implant, and here I say the Straumann bone level or a tissue level implant, you could go a little bit shorter. Why? Because the abutment is also partially, of course, inserted into the implant, which gives already a sort of stability. So there you can go to 5.5 millimeter. And people who are a little bit in the field of short implants will say, hey, Bollen, we also have the 4 millimeter Straumann implant. So what are you talking about? You can even go very short with an internal connection implant like this. Well, be aware they're very good, that there are no long-term data concerning the quality and the stability, osseointegration and long-term data on this implant. So yes, on 3-4 years, we see very good results, but I would like to see 10 years, 15 years results before I could state that this is an excellent situation. Therefore, if you look to this situation, this is a case done with a 4 millimeter short Straumann implant. You see in the baseline the 2 implants. If you as implant dentist or dentist would say, I will make 2 separate crowns, I would say this is a very wrong decision. If you use such a short implant with an internal screwed connection, I say immediately screwed connection, it is best to connect that short implant with another implant to be sure that you have enough support. Now, we had 6, we had 5.5, and then we really come to the ultra short implants. Ultra short implants are only possible when you use a deep conical connection. That means, for those who are not aware what eye systems, or in this case also Bicon, but immediately I talk about eye systems, is there is no screwed connection between the implant and the abutment. It is only a deep conical connection. And in this way, Bicon could go to a 5 millimeter length implant, and eye system even has a 4 millimeter high implant. So that is really ultra short. And let's be very honest, shorter than 4 millimeter will be impossible to make as an implant. What is the trick? I said the other implants all had a screwed connection between the implant and between the abutment. But if you are using a deep conical connection, you will have an intensive contact between the 2 treated surfaces, the inner surface of the implant and the outer surface of the abutment. And when you press them together, when you push the abutment into this implant, that creates a stable atomic lattice. Now, in components with high surface quality, and we can all be assured, especially for the eye system, the quality of the products is very high. So that means when the inner surface of the implant is very flat and very smooth, there are no irregularities. And when the outer surface of the abutment is also very flat and smooth, well, then the metal atoms touch each other when you've pressed them together, and the interface of the forces give a sort of attraction between the two components. And that we call the cold well. So when you have the connection between the implant and the abutment in these very ultra short implants, keep good in mind, there is no screw retention. It is only by pressing, tapping them together, and at the end, it will create a cold well between the abutment structure and the inside of the implant. And this is a very important slide for me. Why? Because not only it shows you that when you tap in the abutment or the healing abutment into the implant, that there is a good fit, but there is an extreme optimal fit. If you look, and you could go, and we will see in another slide, higher magnification, if you look to the gap between the abutment and the implant in this eye system implants, you see that this gap is less than 10 micrometer, even less than 0.5 micrometers. So here you see a very high magnification, implant and abutment, and that gap between those two components is less than half a micron. Now, I did some microbiology to reach my PhD, and if you then take some bacteria and I put a spirochete and a Porphyromonas gingivalis there, and this is the exact magnification that you need for the gap that you see between the two components, well, you can agree with me that it will be almost impossible for those bacteria to penetrate between the implant and between the abutment. And how can you check this? For those of you, and I think most of you, who do implant dentistry, when you remove an abutment from an implant, even a healing abutment, you smell really terrible things. Why? Because there is micro leakage between the components of the abutment and the implant. Because, and we will see it later, the gap there is not half a micron, but 10 to 20 micron. So that is a highway for bacteria to go to the internal part of the implant. When you remove an abutment or a healing abutment from an eye systems implant and you smell at this part, you will smell nothing. Why? Because bacteria just cannot penetrate such components into the internal part of the implant. This is a Bronnemark implant with an abutment. And these scanning electron microscopy pictures show you that the gap between the abutment and between the implant is nearly 20 micrometer. Well, if I go back then and I show you these bacteria, then you can understand that this is a real highway for them to go down into the depth of the implant where they cause the smell, and the bacterial leakage that they cause there at this connection is also responsible for peri-implantitis. Now, if we go short, let's say we go short and we go to 4 to 5 millimeter of the length of an implant, we have to go wide. We cannot say, as I said before with that very short Straumann implant, if we go short, we keep the same dimension. Then we have to go wide. Why? Because we want to create the same bone implant contact for short implants in comparison to the regular ones. And if we want to have the same bone implant contact for short implants as for regular or long implants, we can do two things. First of all, we can make the implants wider, so then we create a larger surface, or we can change the surface area so that we create also more surface. Well, here's an example. If you have a standard implant, let's say a Straumann implant, tissue level implant here of 12 millimeter and 4 millimeter diameter. And you know, these are the calculations how you can calculate the surface of this kind of cylinder. I call it a cylinder. I'm not going into detail about the windings, but let's calculate it as a cylinder. Then it means that if you want to go to a diameter of 4 millimeter, of a length, sorry, of 4 millimeter of an implant, that you need a diameter of 12 millimeter. And I'm very sorry, probably technically Every company can create an implant that is 4 millimeter height and 12 millimeter wide. But we, as professionals, you have to tell me in which jaw I can introduce such an implant. Maybe in a distal area in a lower mandible, I could place an implant that is more than 1 centimeter in diameter, but for most of the cases, we can't use this. So it's not an option to say them, make them so wide. You can make them wider, but not 12 millimeters. So what is then the second option? We make them wider, but also we change the design. We make plateaus. The macro design is changed. It is not a screw, but it are plateaus. So for those who are going to use or will use this system, keep in mind, these implants are no screws. These are plugs with plateaus. You tap in the implant. We see that later. It's not screwing in the implant. If you have this kind of implant with plateaus, you will have an enlargement of the surface area of 30%. And we will see that that gives also much better force distribution and at the end also better bone quality. So what is the trick? If you want to go shorter, you go wider and you adapt the design by creating the plateaus. Here is a comparison between different implant systems. And of course, not all implant systems we had the same dimensions available. But if you take a look at the two most extremes, and you have the eye system with a length of 5 millimeter and a diameter, with a diameter of 5 millimeter and a length of 6, and you compare that with a Straumann implant with a diameter of 4.8 and a length of 8 millimeter, you see that it's almost double of the surface. And that has to do with the plateaus, because you see there with the Straumann, the screw windings almost not give you any additional surface area for bone implant contact. Now the plateaus also not only create more surface, but they have more advantages. Yeah, when there is a compression, when there are forces on the implant, and when you have plateaus, then the plateau takes care that the forces are distributed over the whole implant, as you can see on the right side of this slide. On the other hand, when you have a regular implant, you see that the force distribution is located at two specific sites where there is one piece of around the implant where the force is absolutely not distributed. And this was looked in studies in 2010, where they used, first of all, actual force of 100 Newton. And the upper slides, the upper images tree are regular implants of 14 millimeters. And there you see that when you put actual load, that the load is really divided over the whole implant. Whereas if you go to the very short implants, you will see that the force is really, the loading is really in the apex of the implant, what is much better for the remaining osseointegration. The same was seen when you do lateral force on those implants. If you do a lateral force on the implants, and specifically if you have a look at type 4 bone, then you see that in a regular type of implant, these forces are really condensed on the top, the neck of the implant. And that is also then a place where the peri-implantitis could exist. Whereas if you look to the second row in type 4 bone, when you have short implants, the forces are divided all over the implant, which is much better for force distribution and much better for final bone quality and osseointegration. And if you look to that osseointegration, you will see that in these plateaus, and there are a lot of studies done, there's a lot of research out there, you will see that there is a very good bone deposition in these plateaus, causing an extreme good osseointegration. Now, maybe you have an implant clinic and maybe you place a lot of implants or you don't place a lot of implants. And maybe you joined us in this webinar. You said, you know what, why should I use ultra short implants? For the moment, I can do all my cases. I don't need an extra implant. I don't need an extra surgical box and I have to buy healing abutments again and impression copings again, etc., etc. Well, I'm going to explain you why and afterwards when you could use ultra short implants. Why using ultra short implants? Because it is an individual preference. Maybe you like it. And again, here, because I don't want the hashtag #MeToo association behind me, you can probably like short and fat, or you like long and slim. But for me, there is not only just the individual preference. For me, the answer is there. Use what works good in your hands. And of course, there was a time that I also was not used working with short implants. And I thought that I could only do it with longer implants. But as soon as you have it in your hands, then you will feel it works. So that's a reason to use them. If it is working in your hand, if you have the experience, just try it, do it. Would you use them because of publicity? Is it because we are today organizing this webinar, and when you go into a dental exhibition, you see a booth with iSystem, or you see some nice colleagues presenting webinars on this topic? Is that a reason why you should use short implants? No, that may never be the reason. The reason why you use short implants, in my opinion, as an academic person, is only it should be based on scientific data. And there are scientific data. We come back to that. There are more than enough scientific data. So publicity cannot be a reason why you use it. Is it because of money? As we know, everything is about money these days. Well, maybe. I have to admit, and I'm very honest in this lecture, I use it also for financial reasons. And why? Because I have to do less surgeries. Because I don't have to do bone augmentation. I will show you later on. Because I have to use less materials. Less materials, I don't need to use all the time bone augmenting materials like all the stuff that is on the market. And that's why it is much easier to convince my patients. If I can offer them a simple treatment, those patients will probably say much faster, hey, let me do it. And when I can convince my patients, I have probably more patients. I can probably place more implants. And if you make the sum of that, I'm very sure that you can also then calculate with me that you will have more income. So working with short implants could give you more money. Would you do it because there is science? Well, I often have contact, of course, internationally with a lot of people, and people who are not looking into science regularly, they say, well, it's a novelty, short implants. It is not scientifically based. Well, my friends, that's absolutely not true. I went yesterday on PubMed. This is a slide from yesterday. And if you just type in short dental implants, you have 1,809 articles concerning this topic. So that doesn't mean it is a novelty. And they go back for a long time. I may not name the name of a concurrent, of course, of iSystems, but another company who produces this kind of short implants came out with a book of 30 years of experience with ultra short implants. So scientifically, it's 100% proven. And my patients, I don't know how it is in your country with your patients, but they want predictability. I can come up with a very simple, very cheap implant from wherever, but if there is no predictability at all, patients will not go for this kind of treatment. Indications. Is indication a reason to use ultra short implants? Well, yes, I will come back to that. Because if you use short implants, and I will show you afterwards, almost all cases can be treated by you. You don't need to do complicated surgeries. You will not have to send your patients to the hospital for extended bone surgery, what causes also hospitalization. And at the end, that means for you as a surgeon, less appointments. And what is less appointments? Less office time, faster results, and I go back to the other point, more income. So indications play a role to choose for short implants. Is it safe? Could safety be a reason to choose for short implants? Well, again, yes. Why? Because we don't have the problem of nerve damage in the lower jaw. We don't have the problem with extended sinus perforation in the upper jaw. We don't have the problem with collateral root damage when we have convergent roots, for instance, in the front area in the upper jaw. And what is very important, you don't have to send your patient so often to a cone beam CT scan. And maybe your patient like to have from time to time a CBCT, but where I have my clinic in the Netherlands, we still work with the ALARA principle, as low as reasonable achievable, meaning if you can do it without a lot of extended x-rays, you should do that. And if we don't do that here in that country, we get problems with the government. Is it fast? Would you use short implants because it's fast? Well, again, there, yes, because you have to do less surgeries. If you do a regular bone augmentation and you use a regular product, in my opinion, you have to wait 4 months before you can do your implants. And if it is in the upper jaw, I wait still 4 months before I'm going to use then make my crowns or my prosthesis on it. So if you don't have to do a bone augmentation, you will save time. You will also have shorter surgeries because you don't have to do a lot of bone augmentation, causing less healing time. And those criteria are all advantages for the patient and advantages for the surgeon. The morbidity, is that a reason why you would work with short implants? Well, I guess yes, because less surgeries. And if you also do this kind of therapy, the surgeries are less invasive. That means you have to give less medication. You don't need to do autologous bone grafting. I know a lot of people love to do all of this kind of things, but if you can avoid it, why should you do it? And you only have one surgical site. So for the morbidity, could also be a very good reason to choose for short implants. Accessibility. Is that a reason to use short implants? Well, yes, because if you use short implants, you can yourself perform complexer cases in your own private practice. That means you can perform more cases. That means you don't need to refer all those patients. I have a referral practice as periodontist implant dentist, and I see always that dentists who refer me patients are still afraid that they will not see the patient back for making the crowns and the superstructures. And the same is for you. If you send a patient to the hospital because you need an augmentation with hip graft, you also will probably be afraid that you don't see the patient back, nor for the implants, nor for the superstructure. So if you can do all the cases yourself, you don't have a problem with getting the patients back, and they don't need hospitalization. Which patient today in this COVID times is waiting for, yes, I get a hospitalization. Yes, I'm happy with it. So you don't need it. And finally, the word of this decade, well, maybe of the last decade, stress. We all have stress. Everyone has stress. So if you use short implants, maybe you have less stress. Yes, because you're performing standard surgery. That means you remain in your comfort zone. And I can imagine from time to time, me as a surgeon also, I like to be challenged, and I like it to do from time to time a more complex case. But if I can do standard cases and make my money and have happy patients with less failures, then I'm happy as well. And for the patient, it's important because less failures for them, it means also that there is no loss of the investment. Because in every country, it's of course difficult, but if you lose dental implants, someone has to pay to do it again. And maybe you say to the patient, well, if we do it over again, you have to pay it over again. But again, I talk about my situation. In the Netherlands, we can't do that. If you have to do it again, I have to pay it. So if I use something that is giving me less failures, I have to do less things again. And that gives me less stress. Now, that was why we would use these implants. The question now, and maybe the most important part of this lecture is, when could you use ultra short implants? When are you really needing them? In which cases in your practice? 1. Well, when sinus anatomy is involved. If you have those 2 cases, and I do this every year with my students at my university, I show these cases. The first thing I ask is, what is your therapy? Every student, all postgraduates there in Birmingham, but the first answer is sinus elevation technique, sinus elevation technique. So what they suggest here is a sinus elevation, an open technique, or a summons technique. I hate it. My question to you all guys, all out there now is there any patient coming to your dental clinic with a question to you, dear doctor, can you please do me a sinus lift? Because my neighbor and my aunt, they were here in your clinic and they had a sinus lift and they were so happy with the sinus lift. So I want the sinus lift myself now. None. I'm 22 years in private practice. Was no patient ever asked me to get a sinus lift. And you know what our problem is, dear colleagues? And I had that also in the past. We think we are really big surgeons if we can do sinus lifts. We are so proud that we can work into the ENT area that we can do big surgeons, because after the big sinus lift therapy, we think, wow, for our egos, let's see what we did. What a great surgery. What a complete nonsense. What a complete nonsense. You can avoid more than 75% of your sinus lift cases if you work with short implants. But of course, it's not so spectacular. And a lot of us want to be spectacular, because if there then is a meeting of dentists, they can say, oh, I did 80 sinus lifts this year and I did 20. You know, I have a lot of experience, and I can't hear this bullshit anymore of all those colleagues who just want to say what they did because they are so proud and they need this for their ego. Probably at home they have nothing to say, but then they have to be very, very important in their clinics. Avoid sinus lifts when possible. No one is waiting for a sinus lift. Of course, there are cases where you can't do it without, but for the rest, it is completely overdone. And we should avoid it. And I think there should be a regulation also coming out. It would say, you know what, there is an alternative. We don't need this. Because if you see this case, these are 2 short implants placed where there was no sinus lift done. And it works perfectly. And if you make an informed consent for your patient, and you don't tell your patient that a sinus lift can be avoided when you use short implants, then you are wrong and you can be sued. So maybe that's a good reason to stop working with sinus lift and start working with short implants. The second reason when to use is when the nervus mandibularis is involved, the mandible nerve. If you have this case here and you see 2 slides, there is not much bone. So what do? We want to play the big surgeon again. Yes, we are going to do bone augmentation, and we're going to follow in Hungary very important courses with István Orban, and there we learn how we can augment, because then we are very important, and we take the bone from the chin or from the ramus. Jesus, what we are such a big surgeons. And even I have some colleagues who do nerves transpositioning. I'm very sorry, I had a very long training. I have 4 diplomas and I never did a nerve transpositioning, because that's complete bullshit that ever existed. This is not necessary. This is taking extra risk where there are other options. So don't do this, because this can be very easily solved by short implants. You see it here, 5 millimeter long implants. The nerve, of course, is very close, but you don't need nerve transpositioning and you don't need extensive bone augmentation. So when the nervus mandibularis is involved, short implants can be of use. Extreme resorption. This case, of course, you would send it then to the hospital, and they will take a hip graft, they do destruction osteogenesis, and then we all know that the quality of the bone that we take out of the hip is not the same quality than we have in the mandibula, so we get resorption at the end, and we know that a lot of cases go very well, but we also know that a lot of cases don't go very well. There is an alternative, my friends. You can work also here, not only with this bone graft or with the destruction osteogenesis, but you could use ultra-short implants, and it works. There is documentation. Go and look on PubMed. It works perfectly. And finally, if you have convergent roots like this, and there is not enough space, what do? Well, the option is to make a sort of removable prosthesis with 2 teeth, and that is something that is, well, for people who can afford, not an acceptable solution anymore, something like that. So often bridges are made. And if I go back to this slide, this young patient, would you make bridges here? I would not. But you can do it with short implants, very short implants that can be placed in these very small areas. And that would save you a lot of problems with grinding the tooth and making bridges. So there are a lot of indications where you could really use it and where you could avoid a lot of extra surgery. But then I come to the biggest question of the whole stuff is, what about the crown implant ratio? Because if I go back to a few slides and you see this, I think it was this one, you see already that this crown is much longer than your implant. And what are we used? We are used that an implant should have the same length as a crown. I go back where I was. This was what we learned in 85. Adele came with studies and he said, you know, if you have an implant of 1 centimeter, then your crown and abutment should also be 1 centimeter. And if you have an implant, a crown and an abutment of 1.5 centimeter, then you should use a 15 millimeter long implant. This is absolutely not true anymore. I make always this comparison. If you have the Eiffel Tower, and the Eiffel Tower in total is 324 meters high. Do you think that the French made a hole of 324 meters deep as a fundament to put the Eiffel Tower on? I don't think so. I don't think they made a hole of 324 deep. At least I know they didn't make a hole of 324 meters deep. What they did is to make a larger platform. So the same is here. If indeed you will have to go not so long, not so deep, you have to go wide. And that's the reason why, if we talk about short, ultra short implants, it should be /wide, very wide implants, because just making something very short with a regular diameter will not work. If you make something short, you have to use a wider diameter. And that is what you see here. For the Eiffel Tower also, I don't know exactly how wide it is, but it is of course much, much wider than the depth at the end. Now, if we go back to the teeth, and if we go back to the situation there is a lot of study material, and we know that from our dental training, telling us that if you work with irregular teeth, then you should take care of this 1:1 ratio. In that case, because there is a periodontal ligament in between the tooth and the bone, then we have to be very careful. If we make a too long on, then with the periodontal ligament, we will at the end have too much load on the short root, and we know all what happens then. After a while, there becomes mobility, and the mobility becomes extreme mobility, and that gives us infection, and this infection causes then the end of the tooth. For an implant, this is absolutely not the case. For teeth, yes, the 1:1 remains important. For implant, it is not. Now, studies proved, and if you go on PubMed, you can find a lot of studies on that this crown implant ratio is really not an issue, and it is not only for long implants, but also for short implants. But there is a limit. If, of course, you have a very long abutment and you have a very long crown, then the lever arm increases. And of course, this gives pure physically some increased risk for overload. So if you see in a case where you have really very long crowns with long abutments to cover the whole distance to the occlusal surface, then it is advised to use more short implants and to splint those short implants. So in those cases, I would say, like here you see on the X-ray, two short implants, but two connected crowns, so that the forces are divided over the two implants that are used. But as you can see here, crown implant ratio 2.3, 2.07, and also the other one in the upper jaw there, where there was not much bone available in the sinus area. There is a very long crown on it. It can work perfectly. Of course, in my opinion, but that is not only for dentistry, that is for whole life, don't go always for the extremes. If you want to check out if you can make a crown of 2 centimeters on a 5 millimeter implant, probably you will get problems. So try to be reasonable, but on the other hand, forget the paradigm that crown implant ratio should be 1:1. And I think this is one of the lessons that is the most difficult for my students when I am at my university, because everyone is still so dogmatic with the 1:1 ratio. And for the moment, we are 100% sure that for implants, it doesn't play a role. Here we talk about very short, ultra short implants. If you talk about regular implants, let's say you have an implant of 8 millimeters, of course you can put a 12 millimeter abutment crown construction on it. There is absolutely no problem. So stop focusing on that paradigm. Some small introduction. A small intermediate topic is science, of course. I tried not to put hundreds of articles to prove that short implants work, because I think those things you can do at home when you have time. You can look in PubMed, you can read scientific articles, or you can buy a book where you can find it. But I just selected very shortly 4 major studies that, in my opinion, are very important. And I only went to the conclusion, because I'm not going into detail about what the study protocol was, etc. Because you can imagine it's Saturday afternoon. For me, at least, it's Saturday afternoon, almost 2 o'clock, and no one for the moment is interested in a lot of scientific stuff. So I'm just going to show you 4 articles that, in my opinion, tell really the story and the truth about short and ultra short implants. The first one is very recent, and the title there is Evaluation of Different Heights of Prosthetic Crowns Supported by an Ultra Short Implant Using the Three-Dimensional Finite Element Analysis. To come to the conclusion, they put it on 4 millimeter length implants, crowns of 10 millimeter, 12.5 millimeter, and even 15 millimeters. So keep in mind, 15 millimeters crown abutment and 4 millimeter of implant. And there was absolutely no difference. Of course, very, very important, that is the disocclusion pattern. So it is very important to check the occlusion if you do this. And to be honest again, I would not go to the limit to say I have a 4 millimeter implant and put a 15 millimeter crown on that, because that's a 1-on-4 connection. That is for me a little bit the border. But if you use it, it's very important that you look to the occlusal scheme and prevent oblique loads during lateral movements. If you can avoid that, and if you have a very good occlusion, then it doesn't matter how long your abutment is. If you and your crown, you can use a short implant. If you really want to try it in the beginning, I would advise you install 2 implants and connect the 2 crowns. Then you are 100% safe. The second study, and it was one of the first that gave really international attention to these short implants, because a small anecdote in between, and I may not mention the name of the other company, but one company started really with these ultra short implants, and that company is already 30 years on the market, and the whole American army, for what it's worth, is using that implant system. It is exactly the same, almost the same as the ICE system. And what is the good thing behind this? First of all, they have 30 years of scientific data, and it works perfectly. Secondly, also, these implants, connections, as we will see later, are all the same. So it means also for you, if you have in your clinic, you use this implant and you refer maybe to another dentist, or another dentist referred you the patient you did the surgery and he has to do the crown, he in fact doesn't have to call you to tell you what is the length, what is the connection, what is the diameter you used, because everything fits on each other. We will only talk about the internal diameter, that is from 2.5 to 3, but for the rest, everything fits together. So that means you don't have to buy a lot of material. You need one surgical kit, you can do everything, every diameter, and everything fits. So that is quite easy. That's why in the beginning of this century, it was mostly Frank Renoir from France who did this study. And he studied the impact of implant length and diameter on the survival rates. Because in those days, the general opinion was short implants with a larger diameter, now it will not work. Well, his conclusion was that the survival rates for short and for wide diameter implants was found to be comparable with those obtained with longer implants and standard diameters. So in 2006 already, that's 15 years ago, it was stated in the clinical or implant research that the success rates of short, wide implants is the same as with longer, regular implants. So my question then after is, why would you still use longer implants? But again there, it's a paradigm change. Because what do you now, a surgeon? You look to your x-ray, you see there is 12, 15 millimeters of bone height. What do? You go to your stock and you take a long implant, because you say the longer the implant, the more bone to implant contact that I have. Okay, for the type of implant that you're using, where the bone to implant contact is less because it is a cylinder, it is correct. But if you would work with short implants, and even if you have 15 millimeters of height of bone, I still use a 5 millimeter long implant. Why should I drill so deep? Because it causes more trauma to the patient and it doesn't have any added value. So you have to change your mind if you go with this study and say, we don't need these long implants anymore to be happy. We don't need these long implants anymore to have success. And it's very difficult because I see it in my own clinic. I have those iSystem implants always in my stock. And often I say to myself, okay, I see the bone between two teeth. Oh, I can put here a 10, 12, maybe 14 millimeter implant, if I'm not working with iSystem at that moment for my referring dentist. But it's not necessary. So paradigm change again. Third study, 2030, a meta-analysis of single crowns supported by short, less than 10 millimeter implants in the posterior region. Well, single crowns supported by short implants in the posterior region are a predictable treatment option with reduced failure rates and without any complications and minimal bone loss. But here again, I just mentioned it, if you talk to your implant company, be very specific if you want to work with short implants, what short is. Because if I looked at this study, you will say short implants work, but they are shorter than 10 millimeters. So that could be an 8 millimeter implant. For me, an 8 millimeter implant is not an ultra short implant. For me, that's a standard implant. Maybe if you look to all the implants that you have placed in all those years, and I keep a record of this, I did some 12,000 implants now, and an average in all that time, I could say the average diameter will be around 4, and the length will be 10 and 12 millimeter. That's the average that you will use always. So short implants, if you want to work with them, of course, iSystems has a very nice range of implants of that. But if you want to really go with short implants, they have to be shorter than 6. And there are not much companies on the market for the moment who sell those implants, especially not with some scientific data behind it. And the final article was from last year in the Australian Dental Journal. Extra short implants in the prosthetic rehabilitation of the posterior maxilla, a little bit again, but they're not short implant, but extra short implants. And that is in comparison by the former article that I just showed you. Extra short implants and regular implants, in fact, show the same clinical outcomes during a 12 months follow-up period. And again, I repeat, I have to be very careful. I don't talk about another company, but we have 30 years the results of these ultra short implants, but not of regular type implants. We have 30 years of results of these plug implants that have a conical internal connection and that are no screws but have plateaus. Those implants, if you go to 4 and 5 millimeter, will work for 100%. For the rest, as I mentioned before, with the very short Straumann implant, I have my fear that it only works when you connect it to other implants. Now, I see that we are almost 50 minutes on the way, and this is in fact the first time that I really want to talk about iSystem. And iSystem is in fact everything that we would normally plan to talk about today. But the rest until now was a sort of introduction to show you where you could use your implants, when you could use them, what is the rationale, what you could change, what you have to change in your mind if you want to work with these implants, and especially don't be afraid. Don't think that this is a novelty which Novo then brings on the market just to experiment with something that is completely new. No, this is really scientific based. It is sure. It has to work in your hands, but you have to build up experience because it's something completely new when you start with it. Okay, part 2. Let's talk about the iSystem in general. Well, the company Novadent is selling this iSystem, And since I'm not sponsored by Novodent, I'm not going into details, but I just wanted to mention that iSystems is the press-fit implant system from Novodent that for the rest also, of course, has zygoma implants, bone and tissue level implants, and very small, thin one-stage implants. These are these screws, and you see they can be very short. Now something is going automatically, and that is not what we want, so I'm going back. These are the screws from a very short to a longer one. And the shortest is 4 millimeter, the longest is 10 millimeter, as we will see. These implants have a very specific surface, and we call it the eye mimetic surface. And that surface, what has an excellent surface roughness and is treated with acid etching to make it rougher and sandblasting, that has an excellent surface roughness for osseointegration in any bone type. So it is not only in type 1 or bone type 2 that you can use it, you can use it in all bone types. Even in type 4 bone, it will work perfectly. And here you see more in detail the surface, acid etched, sandblasted, and the roughness. Don't ask me exactly what the RA, the surface roughness value is, but it is a value that is very good in comparison to others to get good osseointegration. And what is very important, I am ambassador and honorary fellow of Clean Implant. And Clean Implant Foundation is a German foundation. And what does that German foundation? Please have a look at their website if you have time, because it's very interesting and very important. They ask every implant company to send them some samples of their implants. And then Dirk Dudek, who is the chief, Dr. Dudek, who is the chief of the company, does some investigations on very high magnification, spectrometric chromatography, to see what kind of stuff is at the surface of these implants. And you will be amazed what you will see. A lot of implants have all kinds of dirty stuff on their surface, from metals to plastics or whatever what. So in that way, Dirk Dudek made a sort of label that every implant system could get if they have a clean implant surface. Because that clean implant surface is not important for you as a surgeon, but is important for your patient. Because if there is a lot of dirt on these surfaces, that could be one of the explanations why we are losing implants, because why we have perioimplantitis. So in 2017, this eye system was investigated by Dirk Dudek, and he saw at that moment that the implant surface was completely clean. A little bit strange, but of course I have nothing to say in the organization as ambassador. They want every year a new sample to investigate, so that you can get every year your new stamp that you are clean. Okay, I can understand that, but on the other way, if an implant is found to be very clean and they continue using the same procedure to produce it, I think it will not change very much. But you would be scared if you see what you find on some very famous implant products. And if you see that, you would say, I would not like to have this in my mouth. Concerning questions and answers, my friend, I'm going to do that at the end, because I want to go on with my story, because otherwise I'm going to change from left to right with answering. And then I have all the time for questions afterwards. So feel free to type them in. I will come back to you in, let's say, 40 minutes when we finish the presentation. So clean implant. This implant is clean as found by Dudek. If you look to the range of the sizes, important, you have 4 millimeter, and that is the shortest bone level implant in the world. Congratulations, iSystems is the shortest, and it goes up to 10 millimeter of implant. But in fact, my friends, if you believe, and I do really believe, in the concept of these plug implants with plateaus, with high surface range, I have to be very honest, throw away the 10 and the 8 millimeter length implants, because you don't need it. You don't need a 10 millimeter implant of this, because it's a waste of titanium. With 4, 5, and 6, you have more than enough. But okay, they are in the portfolio. And if you look to the diameters, you have 3, 3.5, 4, 4.5, 5, 5.5, 6. All diameters available from 3 to 6, and the length We'll see afterwards they are not all in different sizes available, but the length ranges from 4 to 10. Now, what is specific and what is very special at this implants? So, as we said before with the cold well, you have a locking conical connection, and that means that the parallelity between the walls of the implant, there is a 1.5 degree of conical well. So we know that if the walls would be 100% parallel, and you would put in an abutment that is also 100% parallel, you could never get it out anymore. Then you have a permanent cold seal well. But if you make an average 1.5 degree distortion, then you could get it out again. So if you use this, if you tap in the abutment in this implant, you will have no micro movements, as we saw with the false distribution. And as we investigated with investigations that I did in the early 90s of last century, there is no micro leakage. There are no bacteria coming out in and out this connection. So here again, if you tap in the abutment deeply into the implant, then it goes in 3 millimeter deep, and this is a complete closed seal. Here again, some x-rays of that, because this is for me a very, very important feature of this kind of implants. There is a gap smaller than 0.5 micrometer between the abutment and between the implant. What do they have more? They have a sloping shoulder. The sloping shoulder provides space for hard tissue and soft tissues, and that makes the implant placement a straightforward procedure, even in cases of limited mesiodistal dimensions. Yeah, that's one of the advantages in the micro design of the implant. Also, in comparison to the other implant with almost the same design, here they have squared edged fins. And what is the advantage of square edged fins? Well, we have more surface for integration, and it is much more optimal for stress distribution. So also this is typical for this eye system implant, the square edged fins. There is also an optimal interfin distance. Yeah, that is good, again, for optimal biomechanical stress distribution, and that's why these implants work, although short, with a long crown on it. And of course, if you have an optimal distance between those fins, you have more surface for integration. So that means more bone to implant contact. And finally, there's an incrementally deepening grooves. You see on the lateral side, there are grooves, but the grooves going in deeper if you go to the apex, and also that gives a better distribution of the load and gives more surface area for osseointegration. And something that is quite interesting, again, I see the questions, but I come back to the questions afterwards, is the sloping shoulders. Because if you have here almost, if you would place your implants like this, you have almost kissing abutments, as we call it. They're almost coming together. So even if you have this with your abutments, still there is a lot of distance between the coronal part of your implants, and that makes it gives you the opportunity that hard tissue and soft tissue could still be optimal. So if you see the difference here at the left side, you have the situation with almost kissing abutments, with a shoulder that is sloping here for these eye systems, and you have at the other side some general implant where you also have almost kissing abutments. You see there is almost no space in between for hard and soft tissues. And you can see that in this clinical picture. These are two general implants, general design of implants, and if they come very close together, it will be almost impossible to make a superstructure here. And you see there is infection there in between those implants. On the right side, you see two eye system implants, also placed very close to each other. And I can't show you here a higher massification, but you can see probably the white spot here between the implants. There is bone growing on the shoulder of the one implant. So it gives you here a perfect situation, aesthetically at the end, but surely osseointegrating. The surgery. And please, one very important thing, if you are used to place regular implants, then placing eye system implants is something completely new. You need the same equipment, you need the same surgery machine, you need also your same instruments, You need, of course, another surgery box, but the concept is completely different. Now, this is the surgery box. I'm not going into detail because I'm not a salesperson, but what is very important, very, very important, and this is also a take-home message, that the drilling, besides the first drill, but all the drilling during the whole procedure is done without cooling. I repeat, the drilling is done without cooling. And, friends, something new again, besides the first drill that is done on 2000 rotations per minute with cooling, but all the other drills are done with 50 rotations per minute. Only iSystems and Bicon have this protocol. And now very recently, Noble Biocare came up with the N1 implant. Who the hell needs a N1 implant? But there also, they start to do drilling without cooling and on low speed. So this is very specific for this implant, no cooling, low speed. And what is very strange, or what's not very strange, but very interesting, very recently I published an article today together with my dean in Birmingham on COVID-19 and dental implants. What are the impacts and the perspectives? Well, I know you know everything about COVID-19, but if you have a connection between COVID and dental implants, what could we do to be safer? And one of my recommendations in that article, what I can send you if you want to read it afterwards, is that, of course, if you would use a system like iSystems or Bicon, and I don't make publicity for none of them for the moment, that you don't need to cool. And no cooling, no water means less aerosols. Using lower speed with no cooling is less aerosols. And that could be not only now in times of danger for COVID, but also in the future could be something very interesting to avoid problems. Because, my friends, after COVID-19, after the coronavirus, there will come another virus. I think for the rest of our life, we will be facing these kinds of problems. So we have to be sure that in our clinics and with the therapy what we do and the procedures that we do, we have to try to avoid the aerosols. And if you don't use cooling, because you don't have to, and if you use slow speed, because it works, then you avoid a lot of problems. Now, these are the different drills you use, and you have L-type drills and E-type drills. I'm not going into detail. If you're going to work with the system, of course, a local person from the company will explain you all in detail how the drills look. But what is important, that besides the first drill, and the first drill is high speed to make the initial hole, that all these drills have different colors, and that you drill the diameter of your hole to the diameter of your implant. So there is no undercutting, no under drilling. What we do mostly in soft bone, when you do a D4 bone in a maxilla, and you want to install a Straumann implant, for instance, you will not drill a hole of 4.1 millimeter if you want to put in a 4.1 millimeter bone implant. You probably will drill till 2 or 3.5, or maybe to 2.8, and use some osteotomes to make some compression. For this implant system, you drill the diameter of the implant. And the good thing is, and you will see it later on, that if you drill on this speed, and if you don't use water cooling, then you will see on these specific drills that there is a lot of bone chips remaining on your drills. Unbelievable how much bone chips there comes out. Because what you're using now with high speed and water, you're blowing every way, and your assistant is aspirating all the very precious bone. So one of the things here is also that you collect a lot of autogenous bone, what you can use afterwards. So here you see the procedure. This is the high speed drill making the initial osteotomy. And then we go much slower, 50 rotations per minute with such a drill without cooling. And you see in the front, in the upstairs image again, that you can take in the drill, there will be bone remaining, maybe not in the first 2-3 drills because they're very thin. But if you go to the larger drills, and there are different larger drills, and at the end you end up with a drill of 4.5, 5 millimeters, 5.5 millimeters, 6 millimeters. Depends on the diameter of the implant that you can place. And you can imagine if you use a 5 millimeter drill, that a lot of bone chips will remain on that drill, what you have to collect. Don't throw it away, keep the bone. So when you have prepared your drill, and in this case, this is a case what I show you here, that they still want to do a small internal sinus lift, then there is an instrument to break the bottom, the lower layer of the sinus, and then you can bring up the Schneideren membrane a little bit, because you also have a very large hole. You're not working in a hole of 3.5 millimeters. No, you have a 4 or 5 millimeter diameter hole, osteotomy. You can bring in, if you want, some extra bone particles. They are going very high. They should stay inside. And then afterwards, oops, the implant is also going to disappear. But then you place normally the implant at the place where it should be. My implant disappeared somewhere. It's going to heaven, but it will come back afterwards. So this is the procedure. Very important. If you place the implant at the end, there is a sort of Teflon stick that you use to put the implant in place. And then with a specific scissors, you really cut off in the mouth, the tip, and there is a very small Teflon plug that works as a sort of cover screw. So no metal cover screws, no very expensive cover screws to buy, just the metal, the plastic plug of the handle is put into the implant and it is closed. Keep in mind, and we'll see it afterwards, you will have no, I repeat, you will have no primer stability. Those implants you can press in, you can put them on the place. Afterwards, I will show you that you maybe have to tap them, but you place them and you have no primer stability. So it is one of the consequences, maybe a negative consequence for you. There is no immediate loading possible, because if you have no primer stability, you can absolutely not do immediate loading. So this is the implant at the left side with the Teflon stick. You press it in, and then with a hammer and a special forceps, you tap in if it is not deep enough. So that is tapped in place. For the patient, it's a little bit strange because they are normally used to drilling, and now suddenly you're with a hammer like a craftsman tapping in the head, but it's very short. And then you cut off the Teflon plug and you suture. But before you suture, very important, this is the Teflon plug that is cut off. You take your bone chips and you cover everything. You cover your implant under the bone chips before you close. And that's your first step procedure. Integration time, lower jaw for me 2 months, upper jaw 4 months. Now, procedure after the integration is the same as with other implants. You have to make a small incision again, or you do it with maybe with a punch, I don't know. You have a special screwdriver to take out the plug. And when you take out the plug, you can, with a special instrument, take away the overgrowing bone, because you will be astonished to see that the bone is growing over the implant, and you make everything clean, and you can tap in again with a hammer, you can tap in your healing abutment. And then the first situation, the first phase is ready. This is for the lower jaw. Very quickly, when you do the first drilling, it's on high speed and it's with cooling. And then afterwards, you can use all different drills without cooling at 50 rotations per minute to create the osteotomy. And then, oops, the implant is also going to heaven again. I don't know what's happening here, but the implants go to heaven. The implant is normally placed then and it's closed. I want everything, so I'm not going to wait for everything to come, but this is what I told you before. These implants have no primer stability. What I thought when I did my first cases and I tapped in these implants, I looked at my assistant and I said, you know what, I never believed that this will ever integrate. I think I did now some 500-600 of these kind of implants. I almost didn't lose any. It's unbelievable. You place them, there is absolutely no primer stability. And after 2 or 4 months, there is a remarkable stability. So the only point is You cannot use them for immediate loading. This is an overview of all the implants. And the only thing that I really want to mention you is the difference between the well. The well is the diameter of the internal part. Of course, if you want to make a very, very narrow implant of 3 millimeter diameter, like you have there in the purple group, well, then the well, the internal part, can only be 2 millimeter, because otherwise there is no volume of titanium anymore. If you want to go to a 4 millimeter, 4.5 millimeter, you can play with a well that is a little bit larger, 2.5 millimeter. But in my cases, I only use the green ones, the well of 3 millimeter, the standard millimeter. And in fact, I may probably not say that from the company iSystem, but I'm not sponsored. I only buy one type of implant. That's what's circled there. 5 millimeter diameter, 5 millimeter length, worked in all indications. And I don't need a 10 millimeter implant. I don't need an 8 millimeter implant, because the concept is working with short implants and they work in all indications. And 4 and 4.5 is maybe not what I want. 6 for me is too large. So I think 5.5, 5.6 are ideal things to use for me. And again, it's not publicity. It's very easy because I don't need a stock of 25 different types of implants. I only have one type of implant. So if I order to them, I say, send me my implants, 10, 20 implants, 5 millimeter diameter, 5 millimeter length. Of course, without prosthetics, we don't have a crown. So if we did the surgery and we uncovered the implant and we put the healing abutment on, we can start with the prosthetics. The prosthetics, I will show you a little bit on in the way that I show you a case, because I'm more the surgeon, but I do the cases now, also the prosthetic cases. I do them by scanning. I work with a digital workflow because I think this is the future of dentistry, surely of implant dentistry. But this case and the components that I will show you now is done with the analog way with this system. Now, this is the case that we're going to treat. It was a case where already 2 iSystem implants were placed on the position 2.6 and 2.7. There were 2 crowns, and you see the 2 crowns, they were connected to each other. It was a sort of bridge on 2 implants. And element 2.5 was lost. You see it there was a big period problem, so they wait for some healing. Also there, my advice is give the body time. I know that we live in a society where everything has to happen immediately. When I order something online and they promise me that they deliver it tomorrow and they don't deliver it tomorrow, then I'm pissed because I want everything immediately. And the patients also still want everything immediately. And I talk with a lot of colleagues, they think they are very fancy and they think they're doing a better job than I do because they work much faster. But in my opinion, and it's not only my opinion, but it's the general fact, the body needs time to heal. If you have this kind of infection that you see there on this 25, there are a lot of infected cells, there is a lot of infected bone. You can never disinfect it 100%. So immediate implant placement there is for me no go. Of course, maybe you'd like to do it, and of course you do it if you want to do it, but I want to sleep well in the night or do other things in the night, but I don't want to be telephoned by my patient because of problems. And if my patient pays me a lot of money to restore that gap with an implant and a crown, I would love it to be there for the rest of his life. And not after 2 years that he comes to my clinic with the implant, or 2 years, 2 months, with the implant and the crown in his hand and said, can you make me it again? Because I paid a lot of money and it came out. So give the body time. The body needs time to heal. Implant was placed, healing abutment was placed. This is the situation, how it looks. Now, if we want to go to the prosthetic phase, we have to take out the healing abutment. This is done with a regular extraction forceps, but in the kit of the implant company, you have a special clamp to get it out. Now, if you would just pull, you would use a lot of force and will never get this abutment out. So the trick is twisting a little bit and pulling. You have to break, in fact, the cold well, and then the healing abutment is coming out. impression post is gently pressed into the implant, good thing here, you don't need to make an X-ray. You don't need to see whether it's placed in the right position, if it is fitting well. No, it fits in because it's a press fit impression post. So it always is in the perfect position. On top of this impression post, there is a cap placed. So we make an implant level impression. There is no abutment level impression. We make an implant impression. And you can do that with a stock tray, with a medium polyester impression material. I think this is all stuff that I don't have to tell you. It is a regular implant impression. And then afterwards, when the impression material is hardened, you remove the impression from the mouth and you verify the impression fits off the coping completely. So this is like every regular implant, like every other impression, whether it's on regular teeth, whether it's on implants. Then you remove this impression post out of the mouth and you place it in that plastic cap, because that is, I'm going back to tell you again, this plastic cap, that white cap, remains, of course, in the impression, as you see downstairs there. And then you take out the impression post out of the mouth, out of the implant, you place it into that impression and put then the replica on top of it, the replica from the implant. And also there, you don't have to be careful, is it in the right angulation or what? No, it's only press fitting each on each other. Of course, you need to make an impression of the opposite jaw and a bite registration. That's why I like to work with my scan. Still, it takes also time to do a good scanning. But if I make the scanning, the precision is so extremely high. I still do the scannings myself, not that I don't trust my nurses, but these kind of things I like to do myself, because if something is wrong, at least I can be angry on myself and I don't have to be angry on my nurses. So scanning is easier, but it can be done with this regular impression. Healing abutment is placed back and you can tap it in again so that it remains in place. So again, you have to work with your hammer and your instrument to pick the healing abutment on the right place. Then you can choose a abutment. That is what your lab is going to do. There are different kinds of abutments. I will show you some later on, but also for that, I think if you want to know more about the different types of abutments, you have to talk to the company. That's their job. And the abutment in place is then grinded, adapted for the ideal situation. Of course, if you want to bring this abutment correctly over into the mouth of your patient, that will be very difficult, because there is 360 degrees of options to turn this abutment around. If you have an external hexagon, you have six positions. If you have a replace implant, for instance, you have only 3 options. If you have a Straumann, you have 8 options where you can turn your abutment. But here, you're 100% free. So what you need to do is to make a special jig, verification jig, to see on which exact position this abutment is placed towards the neighboring teeth. And then you can take out your abutment, put that jig on top of your abutment, and try in. This is a try-in of the abutment in the mouth. This is the abutment in the mouth, how it should be. We tried it so with the resin jig. And we take again out, put the healing abutment in again, and then finally the crown can be made. Now, this is the crown, made in the lab. And then I come to this important slide. What is one of the most big advantages of this implant system prosthetically? Well, of course, you could place your abutment and then cement your crown on top of the abutment. And then we have the problem, of course, that although you maybe have 20 years of experience, maybe you are the best dentist of your area, but you will see that there are cement rests still remaining under the gums that you don't find. And we know that one of the big reasons of peri-implantitis are cement rests. So what is the good thing with this system, and this is really something I absolutely admire, is that you can cement your crown on your abutment outside the mouth of the patient. So then you will have a situation probably as there in the middle. You have cement too much that is outside your crown, but you can clean your crown outside the mouth 100%. There is absolutely no remaining cement available. You do it with alcohol, with cotton pellets, whatever. Of course, no metal instruments. And why no metal instruments? Because when you use metal instruments on that titanium abutment, you make scratches. And if you make scratches, that would, of course, be a very important place where bacteria will get a hearing again. And then it's very easy. You have to dry very toughly the internal part of the implant, and then you place very softly the crown abutment component into the implant. And before you do the tapping, you ask the patient, close please. And you know, by closing, the implant, the crown, comes on into the exact position where it's needed for the occlusion. And then finally, you tap with some soft rubber on top of it so that you don't put metal on your porcelain crown. You tap in the crown deeply into this implant. And maybe if you never use it, you will think, well, a patient can take it out very easily. No, the cold well makes sure that you cannot manually get the crown out. The good thing is, if you want to get it out, you need again a forceps and not only pulling, but a very little small rotation, and you can take your crown out. So if something happens here in this case, for instance, a piece of porcelain breaks off, some chipping, it's very easy to get the crown out and in your hand to adapt it or repair it. So in this way, it's very easy to remove these kind of structures. So you ask the patient then to close. You check, of course, the occlusion, and you see this is an excellent bite, terrible bite, but the occlusion was done, and you have a perfect result. You know, you had already two crowns on implants on the 2.6 and the 2.7. They were connected. Of course, here we could not connect it, and we have here then a single unitary crown. This is the X-ray, perfect integration. And what is important, what you see already here, and if you see your X-rays again years after years after years, I ask my patients to come on a regular checkup every year. Every 2 years we make a X-ray, and you see then that the bone is really growing over the first plateau and is moving up towards the abutment. This is really amazing bone integration. Abutments, you have different heights, you have different diameters, and you have different angulations. So as I said here, I will not go into detail because this is not really my stuff, but you can have a catalog that can be sent to you by the company to see what all options are. This is not available yet from my system, but this is what I use on my iSystem implants in my clinic. These are scan bodies for the 2, 2.5, and 3 millimeter well. You see 1, 2, and 3 holes. And with this, you can also do the full digital workflow with this iSystem implants. Now, we're almost done, some 10 minutes to go, and I will just show you some cases so that you can see what you can do with this nice system. And then, of course, there is time for questions. Let's see with case 1. This was a patient that already had 6 iSystem implants, and now you see there is a big problem in the first quadrant. Not really much bone, but of course we have only, as last tooth did, to 1/4, so we need some extra teeth over there. This is the intraoral situation. Occlusally intraoral situation. You see that there is a lack of bone in the buccal area there at the 2.4, 2.5, caused by traumatic extraction. And this is when you open up and you see, okay, there is bone, but buccally there is not much bone, so we have to do probably something extra. 3 iSystem implants were placed, different diameters, different lengths, not so important here, but 3 are placed. And there was some extra bone grafting done, and a titanium reinforced membrane was used. And as you can see here, if you look close to the slide, the 3 Teflon caps are inside and are just cut off with a special scissor so that they close up the gaps inside the implant so that nothing can grow inside the implant. Here everything is covered with some metal extra tacks. The membrane is kept in place and everything is closed. And this is the result after 4 months. The healing after 4 months looks good. Reopening, and what do you see? You see still some final particles. Most of them are already resolved or rebuilt to new bone. You see there the plug, and then you remove the membrane. You see the fine integration of the tricalcium phosphate hydroxyapatite bone particles. This was synthetic bone that was used. And then some healing abutments were placed. You have different kind of healing abutments. You have Teflon ones. You have metal ones. The good thing with the Teflon ones is if you don't have the exact height, you can still adapt them in the mouth and you can place them and adapt them the way that you want. This is the healing after a few weeks, and you see the Teflon abutments still in place. And look at the really excellent soft tissue situation on the right slide. You see the internal part, the internal well of the implant, but you see how nice the emergence profile of these Teflon abutments causes perfect situation. This is a try-in of abutments, and on the abutments were already metal caps made. I would not do this, but this is a little bit a slight older case. You could use abutments and put on these white abutments, put immediately the monolithic zirconia crowns, like monozir crowns. And this is the final situation. It looks great. Case 2, or this is the X-ray. And you see there one longer implant, could have used also a shorter one, and 2 very short implants with perfect osseointegration. Case 2, upper jaw with some remnant teeth, teeth that are not really in good condition anymore. So everything was removed in the upper jaw, and in the upper jaw 5 implants were placed. This was a case that was done with autogenous bone and LPRF, a quite extended case. And you see also these implants are quite parallel. The good thing is, if you place those implants in the drilled holes, you still can play with this green parts so that you can adapt a little bit the parallelity of the implants. Why? Because there is no primer stability. You can replace the implants a little bit into the hole in the right position that you have almost complete parallelity. So this is then the situation sutured. The lower jaw were also no teeth, they were extracted. And there 4 implants, short white implants were placed. Of course, if I go back to the X-ray, do you need short implants here? No, you don't need short implants here. But if you work with a system and you don't want to work with 25 different systems, you could perfectly use here short implants. You don't need long or regular or standard implants. So 4 implants were placed. And this is the X-ray after integration. 4 in the upper jaw, 4 in the lower jaw, and there were ball attachments that can be placed on top of it, 2 evidentials, and at the end you can see you have 2 evidentials perfectly fitting on 8 short implants. A final case, and I show you just this because it can be very spectacular what you can do with these kind of implants. It is by Ralph Evers, an Austrian surgeon who works only with these short implants and uses these short implants also in a lot of cancer patients. And what is done here, you see, it is a case, I don't have much slides, but it's just about the concept. This is a patient with, of course, lost teeth and large bone defects. And here, believe it or not, a full bridge is made on only three ultra short implants. And it's not one case because he has a lot of case series and a lot of good results long-term on this case series. But you can place 3 implants spread over the jaw. And the strange thing is, and also there you can find literature, that the central implant is placed inside the canalus incisivum, because we know that this nerve that comes out there doesn't have much function. So the central implant is placed into the canal. You see here there's a big canal, and you can place it inside the canal. So then you have very good bone at all the sites around the implant. A Trinia bridge is made, and the Trinia bridge can even be placed on 3 implants, as you see here. And finally, I will show you this, a lot of X-rays where you can see the amazing results. I think the left slide shows you what is possible. First, a dentist placed there a very long implant. It was even almost in the nose. I don't see the need to use such a long implant because you can see you can do it with a short implant. Also in the front there, you see the slopping shoulder working when you put several crowns in the front. Very short implant there with a longer crown. And here in the lower jaw, a little bit the same. The crown implant ratio of 1:1 is really not so important. You can go over that limit. Maybe connect the crowns, that could be an option. Or like here, put more implants. Don't use not enough implants. And here you see it again, even what kind of construction it works, especially the middle, where there is not much bone above the nerve, you can use this kind of implants. Well, I think that's it a little bit. If you have questions, I will go into the questions now. I think I kept perfectly on the time, even exactly on the time as I see. You can always mail me. Easiest is the last one, kurtbollen@me.com, if you have questions or if you want to collaborate or whatever, if you want to visit the clinic. If you want more information about me, you can see me on the LinkedIn site page and on the 2 websites of my practice. There is Dutch and there is English and there is German translation, so you can see what we are doing. I thank you very much for your attention. I hope there are still some questions and I hope I can answer them. And for those who leave us already now, I wish you a very nice Saturday, a very nice weekend, and stay safe. That's important. Thank you very much for your attention. And let's see what I can do with the questions. Let me go to the questions, put them first here on my other screen. Okay. Please elaborate briefly on I-System drills, kit, osteotomy, abutment, prosthesis, delivery workflow. The drill kit, as I showed you before, everything is inside. I think this question about the material, that is something that you probably should discuss with the company itself, because I'm not part of the company, of course. When you make the osteotomy, it is, of course, first you can do your planning. And if you have CT scan, you can often also find in the library of the planning software of your CT scan, you can find the Bicon system or the I-System, icon of bi-system. Don't change between, but it is just, if you want to have a shablone of the implant, you can use the Bicon system, because the I-System will often be not directly in your software of your CT scan, but then you can use the Bicon shablone, so that you can use to see where you do the osteotomy. And with the osteotomy, as I told you before, first you will have to go very high speed with cooling. Afterwards, slow speed, and you drill. The diameter of the last diameter of your drill is the diameter of the implant that you're going to place. Now, the abutment is placed at the moment when you place your crown, because the slides that are showing that trying out the abutment in the mouth of the patient, that are things that we absolutely don't do in the clinic. There I just make my scan with my equipment, send everything to my lab, and I receive the abutment that is prepared and the crown. I cement them together and I place them into the patient. So that's what I hope is a little bit the answer to that question. What is the fin lengths? Well, I have absolutely no idea how long the fins are, but if you see that the implant is in diameter, let's say 5 millimeter, yeah, and if we have then a well in the middle of 3 millimeter, that means that I maximally have 1 millimeter of fin. And if you then think that, of course, there is a sort of implant body, then I think the fins on top will be 0.5 millimeter, and the fins length in the depth will be, of course, going to 1 millimeter. But anyway, this is something done by the engineers. to see, of course, to make the fins as long as possible, to create as much surface for osseointegration. But on the other hand, you have to also to be careful that this implant complete material is strong enough, because otherwise you could break it. I see my good friend Darko also ask a question. Hello, Darko. Good to read you, not to see you, but to read you. How short could a ceramic implant go, in your opinion? Thank you. I was expecting this question. I didn't know that you were watching, but I was expecting this question. For the moment, Darko, the shortest implant in ceramic is 8 millimeter. And the problem is when we go much shorter with ceramic implants, we could have cracks again. So that's a little bit the problem. But I know from several companies that they are working on a shorter implant, but then also, of course, a wider diameter. Because if you have a standard diameter going shorter with ceramics, then there is a problem, of course, of breaking inside the structure. I mean, not the breaking of the implant, but I mean the connection. Yeah, if you have to screw still inside or you have to cement your abutment inside, then it's a problem. Hope this is an answer. If you have more questions, you can always mail me. Ignore the above question and pleased already by you. Thank you. Oh, I did already answer it. I was a backend user nearly 20 years. Now I am first iSystem user in India. Yes, I have placed nearly 30 iSystem users, but now in India, my questions are, how much fin depth is really necessary in case of fin implants to organize a blood clot turning into mature Haverian canals, Corker type implant fins? Well, I'm not, first of all, to answer that one, I'm not, of course, a technician. And as I said, there are limits. Of course, if you think rational, the larger the fins are, the more surface you have for osseointegration. But of course, you need to have a body, internal body for the connection. And on the other side, I think already, and that's just my opinion, what I give you, a 6 millimeter wide implant is for me already very wide, because you don't have everywhere so much bone. So mostly 5 millimeter of diameter will be the maximum. And as I made the calculation already, if I make a drawing here for myself, the fins can be maximally 0.75, 0.5 millimeter of depth at the top. At the lower part, they can be a little bit longer. Second, do you recommend to place these iSystem implants equicrestal or nearly 2 or 5 millimeter subcrestal? I, of course, prefer to place them subcrestally, as deep as possible. That's also the reason why we put the remnants of the bone chips that come out of the osteotomy on top of it, because we want that sloping shoulder also to be completely in the osseointegration area. 3, do you think if these implant systems are hydro-coated, then osseointegration time is expected? I absolutely don't like coatings because we had very bad experience in the past with hydroxyapatite coatings as well, because their particles can come off. There was a lot of problems with older implant systems, of course. As Darko asked the question, and of course I have 2 topics that are really, or 2 types of implants that really are my favorites in my clinic. First of all, I have to admit I like zirconia implants because I like the material, the bio-inert material. And if I want to work with titanium implants, I love these iSystem implants because I like to work with short implants. And the osseointegration there is the most important thing. The osseointegration of these iSystem / Vicon, sorry to repeat that again, is excellent. So I also, I don't see an extra need for coating them to get better osseointegration. I think if they have to change something, then probably iSystems should develop a better, also a very good digital workflow, because that will be the future. And secondly, maybe some prosthetic components can be updated again. Yeah. Vanko here, greetings from Macedonia, beautiful country. I was there once with my friend Fisnik Kasapi. It's a very beautiful country, Macedonia. I would be a little scared putting an implant without primer stability. I agree. I had the same, and that was I was telling when I did my first implants, and those days it was with Vicon, and I had to put those implants in, and you can press them in with your hand, and they fall completely in the depth. I said to my nurse, this will never work. I think in 4 months, when we have to uncover for the second stage, I will not come to the clinic because this is a disaster. And now really, believe me, and I'm not sponsored again, I repeat it, I'm not sponsored by a company. The most difficult cases, the cases where you don't expect osseointegration, type 4 bone in the upper jaw, it works. And it works although you have no primal stability. So don't be afraid, do it. But it is, and it was the first thing that I said, why should you use it? It has to work in your hands. You have to try it out. And you cannot try this out on a model. And we do a lot of trainings where you get a plastic jaw and you drill a hole and then you press the implant in, a press-fit implant. Wow. But it doesn't give you the feeling how it works. So try it out with support of the company or whatever, or invite me. I come with pleasure over to Macedonia to help you and do it because it works. Is it mandatory for 2 short implants placed beside each other to be splintered always? No, absolutely not. This is a very good question. Let me say that, and I go back to the earlier question. If you start with it and you are afraid that you think, you know what, I'm not sure whether it works, or I'm not sure that the integration, just integration will remain for the rest of the life, then maybe you could start doing to splint them. I, in fact, I never splint those implants because I know that they will also integrate, and I also am not interested anymore in the crown implant range here. So, but in the beginning, if you are not 100% convinced, splint them. It's no problem. If you have 3 implants, it will already be difficult to splint them because then your 3 implants have to be very parallel, of course. That's why you still can adapt by placing and play with it. Really, if you do it, play with the inserts. When you place the implants with just hand pressure, you can play and make them as parallel as you want. And in the beginning, maybe I would connect the crowns. Afterwards, I would not do it. I think the last question here. Thank you, Kurt. I was for sure one of the best lectures I have attended. Thank you very much. What limitations do you think the system could have? There are, of course, limitations. In my hands, and I'm just first of all, because the question is personally, in my hands, it works perfect for single tooth and short bridges. I also did it for overdentures. And next to the ball attachments, they have a very good also locator type thing. It doesn't work for full bridges as a complete horseshoe bridge, because then you need 100% parallelity of your implants, because you have to tap in your abutments. So if you want to do a full reconstruction of an arch, and even if you would use guided surgery, if you place your implants, you're not 100% sure they remain on the exact position where you bring them, because they have no primal stability. So if you have to make a full arch reconstruction, then you have to not to use a horseshoe bridge. You have, for instance, to use 3 bridges, or what you can see on cases, and I absolutely don't like it, they put an implant for every tooth. Of course, if you want to make a lot of money, and of course, if your patients are wealthy and want to pay you, you can do that. But in my country, it's not working like that. So the only limitation for me at the moment is full bridges as a complete horseshoe bridge. That doesn't work for me. The rest, everything is possible. And even if you don't believe it, then I would say try it, because you will see it works for every case. Are there more questions? Anyway, that's why I left the slide with my email address. Please feel free to mail me. Also, people who want to collaborate or whatever, I'm always open for these kind of things. That's why I'm also working part-time at the university. I like to do my job in a clinic, but I also like to help, not only to teach, but to instruct people and to help them, to motivate them. So you can always contact me for that. So I see there are no further questions. No. I see someone who thanks me for the presentation. Well, my dear friends, then I would like to finish and thank you all for your attention. I know it is a hard time, because for the moment there are so many webinars, there are so many things that you can follow. And I also have often that I start watching a webinar, and after 20 minutes, my phone is ringing and I get distracted. I hope at least that you could follow and stay with me during this presentation. I wish you all a very good weekend. And I hope with all of you that you stay safe and hopefully see each other again in the future. Thank you very much and have a nice weekend.